Welcome to Antrim Pediatrics. This session is going to focus on how we have tried to enhance our handover practices and safety in practice through the incorporation of the acronym SKIP. Pre-handover preparation provides essential information at shift change upon which to prioritise patient care. It's been recognised internationally as a high-risk area for patient safety. Admissions and communication at this stage ultimately representing a domino effect and leading to admissions in practice. Standardised communication frameworks have been found to enhance the reporting process further, improving coordination amongst healthcare providers, highlighting priorities in practice, and enhancing continuity in care. In line with this, we developed the SKIP tool in order to address 4 key areas prior to our handover practices. This focuses on sepsis 6, medication prescription, IV fluid administration, and PEWS escalation. The SKIP tool has been incorporated within both nursing and medical handovers. Each morning, the nurse in charge will perform her safety brief addressing the 4 key areas in turn. This enables us to identify any issues that have arisen overnight, any patients of particular concern or risk of deterioration, and any priorities that need addressed regarding ongoing management. These will then in turn be discussed in the medical handover and action taken promptly following completion of same. Key responsibilities at handover essentially involve prompt escalation, accurate documentation, and effective communication. Communicating any staff or parental concerns to keeping in the back of our mind about sepsis 6, facilitating medication oxygen prescription accurately, calculating our fluid balances and performing 12-hour assessments as part of our IV fluid management, and escalating any children with a PEWS of 3 who would be identified as our watchers. So taking each of the elements in turn, we look at sepsis. The initial clinical presentation of sepsis can be non-specific, especially in younger age groups who are unable to vocalise their concerns or complaints. Early recognition and treatment is crucial. Progression to organ failure and shock can often be rapid. Consider these key questions throughout your shift, always bearing in mind if the patient has a PEWS of 4 or more, if they look unwell or are parexic, or if you are worried as a professional or a carer is worried, to always consider progression onto the sepsis pathway to ensure prompt and timely treatment. The 6 key elements should be addressed in turn, putting oxygen on if required initially, performing prompt investigations such as bloods, clean catch urine, and a lumbar puncture, gaining IV access prior to administering your IV antibiotics, which effectively should be delivered within the first golden hour to improve our clinical outcome. IV fluids should be considered for hydration purposes should the child be deteriorating, as well as contacting the consultant on call to ensure they are aware of actions that have been undertaken and changes in management have ensued. Always be aware that inotropes may be required, and for this purpose, the nurses will ensure that a blood pressure is performed on admission and regular PEWS were undertaken in case of clinical deterioration. The sepsis order set is now available on Encompass, whereby if you type in sepsis and select pediatric sepsis, it's a one-stop shop to devising your ongoing management plan. What used to be okay for Cardex is now known as the MAR. We must ensure accuracy in our medication and oxygen prescribing. Always check the dosing is age and weight appropriate in accordance with the BNF. Ensure the correct route is selected as part of your prescription and the drug formulation chosen. Make sure your dose is sensible for administration when the nurses have done their conversion. And a Trust Micro Guide is available on the OLAS app, and this will guide your first-line therapies for a selection of clinical presentations. Following on from the hyponatremia inquiry with regards to IV fluid management, there was an emphasis on safe and effective handover practices, diligence in U&E monitoring and review, and ongoing decision-making regarding fluid choice, and ensuring that competencies are maintained through up-to-date and appropriate training. In line with this, mandatory training is recommended 3 yearly, and the BMJ e-learning must be completed along with the PowerPoint presentations and the case studies that are available online and evidenced by a certificate provided to HR on your arrival at rotation change. IV fluid documentation on EPIC requires the nurses to still maintain hourly running intake output totals in order that we have an accurate fluid balance at shift change on a 12 and 24-hour basis. Blood glucose is monitored 12 hourly whilst they're on fluids to ensure it remains stable. And the medical responsibility obviously is to ensure that our fluid calculations are accurate based on an up-to-date weight. Correct fluid choice is applied when we are doing our prescriptions, and that we are monitoring using these and performing a 12-hour reassessment on a regular basis and documenting these in the patient chart. As part of the Pediatric Navigator, there is an IV fluid balance therapy. If you choose new reading within this effectively acts as a fluid review. You can select if the prescription is appropriate, if the fluids are to continue, if they require modifying, or if they can be discontinued. Putting in a weight will ultimately let EPIC calculate your hourly fluid rate. You can review your UNE results that have been most recently done prior to prescribing your new fluids based on the original fluid rate calculator that we used to use as part of our fluid balance charts. It's always good practice to double check the hourly rate that is calculated, not just rely on EPICs. I is also for insulin. This was introduced as part of SCIP in order to minimize our handover interruptions and allow prompt administration at meal times of insulin for children. For newly diagnosed diabetics and DKA, the policies are available on the intranet. The newly diagnosed diabetics, the policy will actually guide your initial long-acting dose and carbohydrate correction ratios as a starter point. The insulin order set is available on Encompass, and this means you can devise a plan regarding frequency of blood glucose monitoring, the nursing management interventions that are required, hypoglycemia management. Long and short-acting insulin can be prescribed with the carb ratios and correction factors at meal times identified to enable prompt and effective administration by children for children by the nurses off the MAR. Typing insulin into the order and selecting pediatric subcutaneous insulin, again, is a one-stop shop for ordering all insulin for children on the ward. Finally, looking at PEWS, the PEWS score is the Pediatric Early Warning Score. These are the physiological parameters performed by the nurses on a regular basis in order to assess the child's improvement or clinical deterioration. The PEWS greater than 4 would prompt urgent medical review and escalation of care. Don't forget sepsis. Effective communication will identify the watchers on the ward, but it's important to remember that it's not always the number of the PEWS that is important, but it is the trend that has been displayed throughout that shift and your period of care provision. So remain aware and remain astute and monitor the trends throughout your care. Thanks for listening.